we have Dr. Marc Demers, who is here to talk to us about aging with intent.
Great. Thank you.
Thank you.
Hi, everybody. I have to be up here because it's the only way I can change slides. So anyway, welcome, everybody. And thank you, Jess and Mark and Health Coaches for inviting us to talk today. Aging with intent. And what I mean by that is simply how you direct your activity for the remaining years of your life. I'm a retired surgical oncologist. I went to Boston University and I did my training in surgery at Maine Med about 1,000 years ago. And after that, I became very interested in cancer surgery, and I spent 3 additional years at a place called the MD Anderson Cancer Center in Houston. My professional life was spent largely at a very large cancer center in Orlando, Florida. Came back to Maine in retirement. Our kids had settled up here, and I ended up at the Age Management Center, which is a nice little story in its own, but we'll take a pass on that today. So professionally, longevity is something that I've been involved with for decades, trying to keep people with very challenging problems going to keep their lives going on track and well and long. But it's also a personal issue for me. I was diagnosed with very severe hypertension as a young person, and it was very frightening and took a while to get sorted out. And so in addition to taking my medicines, I've done almost everything I can think of to make sure that I don't get an early heart attack, stroke, or kidney failure, and so far so good. So I have both a personal stake in this and a professional one. I've been able to run a practice at the Age Management Center focused on longevity. I'll share some of that with you today, and I'm sure I'm going to disappoint some of you who may be here to talk about that perfect peptide stack or what supplements I need to take to keep my skin glowing, that kind of thing. I will have plenty of time for questions at the end, and we can get to that. But let's start with longevity itself. Who's this guy? David Attenborough, 100 years old. 100 years old. Did y'all see that? 100 years old. For 100 years, he has been, almost 100 years, he has been learning about nature and then informing all of us in the most lovely ways about how we could better interact with the world around us. And anyone who's ever seen any of his work, I think it's incredibly impressive. He is still, at 100 years old, active, independent, doing stuff, and he makes a century on Earth look really, really good. The butterfly isn't part of him. That's a different story. So anyway, that's a painting from the 1600s, and I don't think I need to spell out the allegory there. But it has to do with our mortality and thinking about it. And you wouldn't be here if you weren't thinking about not just longevity, but about mortality. It goes back a long way in human history, back to Cain and Abel. Cain rose up and slew Abel. That's from the Bible. And you might wonder, well, maybe after Cain slew Abel, he might have thought, well, now get up, because he'd never seen a murder. He'd committed one, but he was also witnessing the first murder. And it goes on, if you read further, that Cain became afraid. Cain became afraid. Why did he become afraid? Probably because he recognized that if humans were not immortal, that meant he was not immortal, and that would make any of us scared. And I think some of us have fear looking forward about what's going to happen down the road. In the Middle Ages and in the Renaissance period, people went to great lengths to try to make their lives longer. The alchemists felt that if you could just drink gold, find a way to drink gold, that would provide a longer life. And kings spent a lot of money purchasing unicorn horn powder so that they could eat it. And that's the first collagen peptide. But they did purchase that stuff wherever it was from, unicorns or other. So you're all athletes here, whether you know it or not, because you're all in a race. I'm in it too. But this is a funny kind of race. Nobody wants to come in first. It's more about how how you run your race rather than when you finish. It's about process over outcome, because we all know the outcome. And it's really this race we're running as athletes, because we all have bodies. This race we are running is a bit like the game Tetris, if any of you have ever played that. When you start the game, you know you're going to lose. You know it. So the issue isn't, am I going to win or lose? You're going to lose. The question is, can you survive for enough time to make you proud of your effort, and can you fit the little pieces in really well to keep on going? And that's, in my view, sort of what longevity effort is about. So, no fun to live to 100 years if you're miserable. And so, when I look at what really makes us happy in this world, it's these subtle things that don't have to do so much with physical attributes, but things like, you know, am I pleased with who I am? Am I able to travel, get my own things, take care of myself, or am I already burdensome to those around me? Do I belong with a group of people? Do I have a tribe? Do I have a unique person who's very close to me, who I hold dear? Am I pleased with myself entirely? These are the kinds of things that make a life worth living, regardless of how long it is. And then on the other side of that, there are the unfortunate elements of sometimes growing older, which are the fears, the things that will strip away our humanity before we die. Frailty is one I'm going to touch on here in a moment, but social isolation, cognitive decline, loss of independence, lack of dignity that can occur, and physical pain. I mean, these are all the things we don't want them. I saw this in the New York Times a couple of weeks ago. Has anybody seen this? I love this illustration. About half of the folks as they age are going to experience frailty. We'll talk maybe a little bit more about that. But I thought this image, it's so powerful, because when I look at that woman, there's a lot to look at there. She is not climbing stairs. She's done. She's on a stair. Everybody else is moving. She is not moving. She's holding the railing for support, and her other hand is clutching her chest. Maybe she's out of breath. She's by herself. She's been left behind. There's nobody there for her. Her courage may be gone. And those are the kinds of things that frailty can cause in a person as time goes on. So frailty is a big deal, not only because so many people will experience it, but because of what it does to you as a human as time goes on. So when I look at efforts related to longevity, for me, the goal for patients who are focused on this should be simply to retain and improve those assets that you already have, and to eliminate, delay, or reduce those outcomes that we fear. And that's all it is, very simply. And the rest of it has to do with medicine. But to me, that's the goal. And as a physician with a longevity practice, longevity medicine is just good medicine applied to longevity. There's nothing alternative about it. There's no set of rules that's different from the medicine that we all should be practicing. So longevity medicine is good medicine, and it's really got to adhere to those highest standards of care. If we tell you something is true, we should be able to back that up. We should be able to back that up, if need be, with here are the papers. Here is what I read to tell you this. If something is mere opinion, if it's what I think may be true, I should tell you that as well. And sometimes we do use medicines in ways that are a little unconventional, or we use emerging therapies that don't yet have a standard position in the medical canon. And when we do that, I think we should be very, very clear about it. We should tell you, look, there's not a lot of information about this. What I have looks good. Do you want to try it? And I think we have to be very clear about therapies that aren't yet solid, that they're not yet solid, even though we may believe in them. And finally, and some of you may experience this, and this is something I see very frequently in my own patients, is that we are filling a gap for people where primary care has lost them. There is a general sense that you're not getting a good deal. You're paying a lot of money for insurance premiums, especially if you're family, you're a self-employed person, paying a lot of money, and what you're getting for your money just doesn't seem to be right. You feel like you're getting the bum's rush when you're in the doctor's office, and the reason you feel that way is because it's true. The primary care physicians are under the gun. They feel it, and they know it, and they don't like it. But they know that they've got, okay, I got 7 minutes with this guy, then I got to write the note. I got to bill the guy. All right. All right, what's going on? How are you? Good. And you're almost done. So when we see a patient, we have 2 hours. That's a long time with a doctor, and it allows us to get to know one another. You to get to know me, and me to get to know what's important to you. What are the things you value? What are you looking to do? What goals do you have in the next few years? And at least one of you in the audience is going, okay, finally, the guy's talking about something interesting. This guy's fly fishing. And if you know anything about fly fishing, there's you're casting, but you also backcast, and that's kind of where he's at with that right now. And it's a way to get a little length out there so you can eventually put the fly right where you want it. And backcasting is a very useful tool, not only in fishing. Backcasting is a way to make plans. For example, if I know that I want to be a certain person in 10 years, I want to be able to travel by myself. I want to be able to go to Europe and spend a couple of weeks here, a couple of weeks there. That's great. So, in other words, you can book your own travel. You can figure out if you get to the wrong place, you can deal with train schedules, bus schedules, airline schedules. You can haul your own luggage. You can put it in the overhead. You can go quickly from gate to gate. And you may say, no, I can't really, that's hard right now. Well, if it's hard right now, knowing what aging does to us, how hard will it be 10 years from now when you finally have that time to do it? It'll be a lot harder. And so backcasting allows you to say, well, if I want to be there then, who do I have to be now? And what work do I need to do to make sure that I can get there? You know, if your son is graduating from high school or college and he says, Dad, you know, I'm thinking of climbing Mount Katahdin. And you casually say, I'll go with you. And you know, that's what he hoped you'd say. Well, that's a year from now. What do I have to do to prepare for that? So whether your goal is a year from now, 5 years from now, 10, what is it you have to do today to make tomorrow happen? Backcasting. It's a very useful tool. So there's no school for longevity medicine. There's no residency program. You kind of make it up as you go along, and I have no idea what other people do. So I'll just tell you my approach to longevity medicine, the way that makes sense to me. I trained as a surgeon, and that's how I lived my life. And surgeons are not always the most cuddly people in the world, but one thing is true about them is that we are very much results oriented. We really, on the ground with the person in front of us, did we cause you an infection? Did we cause you to return to the operating room? Did we do you harm? And when you cut somebody open, there's always that possibility. So it's hard to be a successful surgeon if you're famous for the biggest infection rate. You're not likely to fill your office. So being sensitive to results is very important for me as a surgeon, and it's easy to carry that over to caring for people as they get older. So the acronym here, MORE, it's a little silly, but it stands for measure, optimize, reassess, and then expand or elevate. Measure. What do we measure? We measure a lot. We measure the obvious things, blood tests, but we measure blood tests that your doctor will get on you, but others that are not part of the standard routine for your primary care doctor right now. We measure biometrics, and I'm going to talk about what that means in some detail in a little bit, but it's measures of your body content and performance, essentially. For certain people, we measure physical performance. If we're grading frailty, for example, we look to see, how quickly can you get up out of a chair, walk a few feet, and go back. Believe it or not, that's a measure of frailty. Once we measure things, we develop a plan to optimize your assets, reduce your risks, and put you on a program so that you can become more robust over time. Or if you can't become more robust, at least hold your ground. And so the optimization involves many things, and we'll talk about some of those. And then there's a reassessment. Did we achieve what we set out to achieve with you? That reassessment, some of it, if it's blood tests, we're going to see a result in 2 months. Some of it, we need to wait for 6 months for it to mature. Other things, about a year. So reassessment is sort of a constant, what are we checking now? What are we checking? How do we do that? How do we schedule the reassessments? But that's a very important thing, because if we're on the right track, we want to stay there. And if we're not on the right track, we want to switch gears and do something else. Enhance and elevate. Once we get you in a place where you're pleased with results, what can we do to make things even better? What is measured? As I said, lots of things. I'm going to talk about biometrics here, because that's one of the things we offer that really is not part of kind of standard care that your doctor will offer you. Blood tests I mentioned, physical exam, your personal history. If I tell you that exercise is the secret sauce, that you're not going to do well without exercise, that's a hard thing to push on a single mom with 2 school-age kids and a full-time job. She can't exercise right now. So that's one of those levers we don't pull. If I'm talking to somebody who has a family history where everybody's had a heart attack by the time they're 50, there's different things I'm going to talk to that person about, and different prevention techniques than I might talk to somebody whose parents lived to be late 90s. That makes sense? So optimization, what does that include? A big part of that for us is that midlife transition. And here I'm talking primarily about perimenopause, menopause, but also testosterone replacement in those men who have a deficiency. As some of you may know, menopause care has had a 25-year hiatus. Women used to get medication at menopause to help them through that transition, and that abruptly stopped in 2001. It's an interesting story. And even now, gynecologists are reluctantly giving people some hormone therapy, which is a mistake. Hormone replacement therapy makes you live longer, and it makes you live better. So midlife transition is very important. Recommendations about your body composition. We get DEXA scans on our longevity patient, and a DEXA scan takes about 10 minutes. Very low dose of radiation, about the dose of radiation you're going to get walking around planet Earth today. It allows us to look at your bones, the mineral quality of your bones. Do you have osteoporosis? Do you have osteopenia? Are your bones well mineralized so that if you take a fall, you're not going to break your hip? How about your musculature? Do you have what's called sarcopenia? Have you lost so much muscle that if you get nudged on the street corner, you're going to hit the ground? It allows us to look at how much fat you're walking around with. Not just the fat you know about. I mean, I look at myself, I know where the fat is. I don't need to know that again. But it tells us about something very important metabolically called visceral fat. And I don't know if any of you know about the importance of visceral fat. It's a dangerous kind of fat. It's dangerous because it shouldn't be there. And it's dangerous because it gives off inflammatory molecules that can be very harmful in terms of lifespan, risk of diabetes, heart attack, and so forth. We look at improvements in biochemistry, your blood tests. Do you have type 2 diabetes? Can we pull you out of that? Do you have a metabolic disease such that your liver is now injured because there's so much fat in it? That's called non-alcoholic fatty liver disease. Is that where you are? Can we pull you out of that? Do you have a lot of visceral fat? How can we help you get rid of that? And all of these things will add years to your life. As I said, reassessment happens at different times depending on what it is we are reassessing, and that's all I would say here. So enhancement can include things that are standard medical care, and as I mentioned before, it can include things that I'm sure many of you have heard of, peptides. I mean, you can't almost pick up any information about health or longevity without seeing the word peptides. What are those? How do they get used? Stem cells. Years ago, I've had a lot of joint replacements, but years ago I had my own stem cells injected in my knee, my arthritic knee, and honestly, it gave me about a year. I mean, it was pretty dramatic how the pain went away. So stem cells have a place in care right now, and I think that place will increase with time. There was just an article that was profiled in Nature, which is a major scientific journal, looking at people with established frailty. And the way they established that was they just timed how long it takes these people to walk 60 meters, which is not a big distance, but it takes them a long time. And by giving half those people stem cells, even 6 months later, the people who'd gotten the stem cells walked considerably faster. The more stem cells they got, the faster they walked. So I think stem cells as a treatment modality is really in its infancy, and I think in the next few years we are going to see the use of stem cells mature. And there's plenty of stuff about stem cells, are they safe and so forth. I think they are safe, but we need to cover that ground as well. But I think stem cells are emerging as a very important thing as people age. Exosomes. Exosomes are newer than stem cells. They are, it's another name for what are called extracellular vesicles. These are tiny little packets, little bubbles of information. What information? I don't know, but a lot of it is signaling information that if it comes, for example, from bone marrow, it can come from umbilical cords and so forth. It may send messages to various parts of your body that are less senescent than the messages you're sending around your body. And so you may get messages that allow tissues to recover better. Exosomes are still very much in their early stages, and I'm not certain yet where their place will ultimately be, but you'll hear more about exosomes as time goes on. And then some of you may have heard of a medication called rapamycin. Maybe not. Metformin, maybe some of you have heard of this. These are both medications which have been around a long time. When I was a resident, I mean, they were giving this rapamycin out like M&Ms to people who had organ transplants, because at high doses, rapamycin causes your immune system to not reject organs, very useful. But at very low doses, in every organism it has been tested, they live about 15% longer. And that goes for worms, mice, rats, monkeys. They're now doing it in dogs, big dogs, the ones that die quickly. There's no way any of us in this room are going to be here for the human data, so the only information we have that will be useful in our lifetimes is the animal studies. Yeah, biometrics. Why test them? Number one, if I had to pick one test to perform on any human to determine how long you're likely to live, it's a test that goes by the nickname VO2 max. That is one of our most powerful biometric exams. We have a gas analyzer lab in our office where we can do several things by simply looking at the kind of gases you exhale. And VO2 max is one of those. So they are powerful predictors of how long you will live. Secondly, for those people who are looking to make changes in how they live to increase their opportunity for surviving, these are necessary wayposts toward health. If you know that this year you have 7.5 pounds of visceral fat, which is a lot, and you know that in a year you get another DEXA scan and by gosh, that's down to 4.5, well, you still have visceral fat, but you have accomplished a tremendous thing by turning your enzymatic machinery toward health and away from accumulation of visceral fat. So there are important victories that you only see if you look for them that will tell us to keep going in the way we are. And finally, they unmask frailty. They tell us, you do not have enough muscle. Your bones are soft. And so we can identify these things before you trip and fall, before you break your hip, break your shin bones or your arm, before you have a head injury. All right, so these are the tests we run in our office, and I won't go through them all, but these are the kinds of things that we look at. Who are these guys? The ribbon winners from the Pony Club contest out in Lisbon last weekend. Who are they? Does anybody? The four horsemen of the apocalypse, right? Peter Attia, Dr. Peter Attia. Does that name ring a bell with anybody? Peter Attia used this analogy. The four horsemen, the common way that Americans die. So, on to the cheery part of the talk. So here are the big ones. What's the biggest one? About a third of us will check out because of heart attacks and strokes. That is by far the most common way that Americans die. We don't get smallpox too much anymore. We don't get run over by horses. This is how modern people die. Cancer, about a fifth, about 20% of people will die from a cancer. Many more will get cancer, but 20% will die. Dementia, neurodegenerative diseases, this I'm talking about Alzheimer's and the other dementias, of which there are a number. I'm talking about Parkinson's disease, various neurological conditions that prevent you from living life the way you would, that sort of strip away your independence, your dignity for years before you ultimately succumb. And metabolic illnesses like diabetes, fatty liver disease, all of these wrapped up with obesity and non-alcoholic cirrhosis. These taken as a whole strip away about 5 to 10 years from the life of a patient that they could otherwise have. These are profound things. And so, faced with that and this information, you might wonder, well, this is grim. Why bother? I mean, what the heck? Why bother? It's coming for me. And so when I talk about longevity medicine and the benefits it may afford you, what I would say is this, that we have significant impact, but it varies. With regard to things like heart attack, stroke, and atherosclerotic disease, we can really move the needle a lot. So we can make enormous benefit occur for patients with longevity medicine with regard to the risk for heart attack and stroke. Metabolic illnesses, diabetes, liver disease, fatty liver disease, and those things, equally high. Against cancer, not much, and almost everything we do affords an indirect benefit. So there's no exercise that you can do that's going to by itself make you not get cancer. There's no pill we have for you. There's no other treatment. So against cancer, it's very modest. Dementia and neurodegenerative illnesses, I would say it's minimal and unknown. And by that I mean there are maybe emergent therapies that will have an effect, but there's nothing I can tell you about today in that regard. So when I look ahead, and I look 5 years down the road, and I ask what impact can I have as a physician doing this, I think that the two groups of patients that I can most readily benefit in a program that I hope to be able to develop, one would be the prevention of frailty. Now this is women more than men, and by the time you're truly frail, we've missed a good window. Doesn't mean we can't accomplish things, but we want to get people that are, they call it pre-frail. I don't know what that means. We're all pre-frail, I guess, in a way. But so what is frailty? Involves bones that are too soft. So when you have osteoporosis and you fall, you break your hip. Okay, it's a fracture. Lots of people have fractures. But after a hip fracture, about 30% of those folks who have a hip fracture the risk of dying is 30% higher in the following year, and it never goes back to baseline. About a third of these folks, once they have a hip fracture, they've lost their independence. So the idea of meeting your friends for dinner on Friday night, not going to happen. Going shopping for yourself, no, you're not doing it anymore. So you've lost your independence. That's a big deal. Sarcopenia, loss of muscle. You're not strong enough to climb those stairs. You're not strong enough to go on that flight by yourself. You need the wheelchair escort. That's a different kind of experience. Overnourishment, a kind way to say too much fat. Infection, there's some very particular infections can occur in older people. We'll get into another time. And the trauma that occurs as people get frail. So that's, to me, I can make a large impact in that. And we are already making a big impact in the correction of metabolic risk. As I mentioned, the benefits we offer there are quite large. And so looking out to you guys, what is your greatest impact for yourselves in the next 5 years? What can you do? Jess is sitting there in the back, and I know she already knows this. There is nothing that replaces exercise. And some of you here at least are at health coaches. And you can use them in lots of different ways to recover from injury, to rehabilitate yourself from an operation or something like that, to make best use of your time. If you have an hour 3 times a week, you can bet that Jess and the other coaches are going to make that the most useful hour that you can have. They will teach you things you don't know about yourself. And one way that trainers, in my view, are not used enough for is this. Make a goal for yourself. What's your goal? Maybe I want to be able to do that 10K walk next year for heart or whatever it is. I want to be able to walk that far. Tell your trainer that's your goal, and they will tailor-make programs for you to achieve that goal. I think having a goal is always worthwhile. It's part of living with intent, right? It's like, this is what I want to do. Help me get there. And they will. So exercise is there's nothing like it. The trainers here at Health Coaches will help you along the line. I hate this, the information problem. Right now, cortisol, every article aimed toward women in the health sphere, every other article you read talks about cortisol and the harms of cortisol, that it makes you fat, it makes you mad at your neighbors, it causes the GDP to go down. There's nothing that cortisol doesn't do. Cortisol is a very complex molecule. I operated on lots of cortisol-producing tumors. My point is, there is a lot of garbage out there in the health sphere. People are always trying to sell you something. So make it a point when you read this information that if the information comes with a sales pitch, you need other sources of information. So try to make sure that you're getting the very best information available, and there's plenty out there. Social connection. I don't think I need to talk about this too much more, except to say, it is what binds us to one another, and it's the glue that, keeps us whole as individuals too, right? In isolation, humans typically don't do very well. And so social connection as we age, keeping in touch with those college friends, saying hello to the cashier, saying hello to people you pass in the hall. I think those things, as trivial as they may be, they all add up to social connection, which makes us feel safer and helps us live better lives. And so when I say living with intent or living intentionally, what I mean is be clear about the goals you have for yourself. Don't let life simply cause you to just go with the flow. Have goals. Have something you want to achieve in the future, and then go for it. And that's what I mean. And hopefully what I've mentioned today helps you with that. And I know some of you are thinking, I wish you would have talked about peptides. But I've left some time. So if y'all have questions, I'm happy to answer them. These are just some things that I thought somebody's going to ask about. So feel free. I want to thank Jess and the health coaches for inviting me, and thank you for your attention. I'm happy to stand around and answer questions if you have any. Yes, sir.
In your opening comments, Can I buy 15 at a discount?
Yes. In fact, if you see Anne Marie in the second, you can get 15. In fact, anyone can get 15 today for the price of 12. What else?
And how much of your effort circles around GLP-1?
Yeah, so great question. Look, the GLP-1 drugs, they've changed the GDP of the country of Denmark. I mean, these are a phenomenon in our time, and what they've done is they have moved the conversation around overweight and overnourishment away from these people don't have willpower, that's their problem, so a moral failing, into a situation where now, as with high blood pressure, as with arthritis, as with lots of human conditions that are not good for us, now it's a problem for which there is a very sound medical solution. And then the issue was, are these drugs unsafe? And that was an argument against them for the longest time. And it is very clear these drugs are incredibly safe, and they may provide benefit far beyond simply the weight loss. They may provide benefit in metabolic ways that extend years out. So these are very sound drugs. And then some people say, well, what about Ozempic face? I don't even know what that means. I mean, I see people on Ozempic all the time. Well, I don't even know what Ozempic face is. Anybody who loses a lot of weight, their face will get thin. I don't know that that's Ozempic face. But does that touch on the questions you were asking? In other words, I think these are very sound drugs. I think they make a great deal of sense for weight loss. I don't think in certain people they make sense as a first step. Example, one of the problems with some of these drugs is you lose not only fat, but you lose muscle. And there should be no one in middle age who wants to give up 1/10 of a pound of muscle for the reasons I've stated earlier. Most women, by the time they're 50, are not making testosterone anymore. And that happens before menopause. Women who are taking testosterone, who are weightlifting, have a muscle-sparing benefit of that, such that if you get a woman on testosterone and then she is still overweight, you can more safely put her on a GLP-1. She will lose the fat and preserve the muscle. And if you're wondering if that's actually true, all you need to do is look what happens to professional bodybuilders before a show. They have figured out ways to retain their muscle and lose fat. And it's a trick that's been there for a long time, but it's one that we can employ for people, men and women, but in this case I'm mentioning women, to make the GLP drugs better in the sense that you don't lose muscle. Any other questions about the GLP-1 drugs? Yes, ma'am.
Is it safe for people, older people? I mean,
Yeah.
in their 80s?
It's not so much your age as much as other infirmities. I have a woman who's 81. She is a single person, lives by herself in one of the communities not far from here, retirement communities. She still goes to Mexico by herself every year. She works out all the time, loves working out. And 81, you bet, put her on GLP-1s after testosterone, and she is really happy, and it's been safe, and it's been a year. So it depends on other infirmities you may have, not so much the number.
What if you have high blood pressure?
What, I'm sorry?
What if you have high blood pressure?
No, not a problem. Most people, by the time you're 60 or so, about half of us have that. So as long as that's controlled, that is not a problem. Yes, ma'am.
Can you speak to why you have high-intensity interval training up there? Because I am reading, I was a fan of Orange Theory for a really long time, and I really enjoyed it. But then, what you read is, no, you only need to lift. No, you only need to stay in a moderate, cardiovascular zone.
Right.
All these sort of modalities are pitted against one another, and I'm sort of
Yeah, it's a
cardiology nurse, and I think there's no bad exercise. But could you speak to why you have that up there?
I do. Yeah, I will. Thank you for that. High-intensity interval training, that is, for those of you who don't know, those are short bursts of highly intense activity, brief period of rest, high-intensity activity, brief period of rest. These are not comfortable to do. Nobody can do it a lot. Nobody should do it a lot, but they're very important. Who are they important for? If you have visceral fat, that happens to be, in terms of aerobic activity, the stuff that makes your heart beat quickly, in terms of aerobic activity, that is profoundly important. It just empirically turns out to be true that if you do high-intensity interval training, you're more likely to lose the fat. I suspect that has to do with growth hormone stimulation, lots of other hormonal changes that high-intensity interval training affords you. The other kind of aerobic activity, which I'm just going to say zone 2, which is much lower intensity, longer period, has all kinds of other metabolic benefits, but HIIT is particularly beneficial in the case of people with metabolic disease. And I'm not sure what all the mechanisms are, but that's why I have it listed. Sure. Yes, sir.
Historically, in public and private insurance, doesn't really pay for preventive medicine very well.
I'm sorry, I can't hear you.
It doesn't pay for preventative medicine very well.
Right.
This seems like the definition of preventative medicine. So for those folks that don't have access to extra money, how does one access this?
Very good question. I would say that there is a heck of a lot of stuff you can do by yourself. For example, all the exercise stuff that we would prescribe, you can do. You don't need us. All the nutritional information that we would provide you, you can access by yourself. The measurement that we offer, some of it you can do by yourself. You know how much weight you lift. You know how far you can run in a certain period of time. You can measure a lot about yourself. This watch, there's more information about how I do things than I'll ever learn to use. My heart rate, steps, my swim strokes. I mean, unbelievable amounts of information. So we measure some very important things, and it's costly. But you can measure very important things that cost you nothing. So I would say a lot of the measurement is out there for you to do yourself. The exercise, the nutrition, that's there. Some of the stuff we do, it unfortunately, just costs money. So does that answer the question?
Sure.
Yes.
One of the things you didn't mention, and I wondered your thoughts on it, is detoxifying, taking toxins out of your body as part of the healing and longevity project. It's in its infancy, but I think that it's an important thing to consider that you didn't seem to have up there.
I don't have it up there. And the reason I don't have it up there is because I don't know what that means. And I don't mean that glibly. I mean, I have a liver and I have kidneys that they're working really well, and they take care of all the detoxifying that I need to have. We have microplastics, right, throughout our environment, and they're testing all kinds of human tissue. Oh, microplastics are in your fat. They're in this organ, that organ. And that's probably important, but I don't know that specifically we can detoxify with that or need to. Heavy metals. Some people go on to have chelation therapy to get rid of heavy metals. Some people believe that taking lemon juice and olive oil will help get rid of gallstones. So there's a lot of things that are called detoxification. I just don't know what that is, and I don't know if there's any benefit that I can relate to a longer life. So I need to sort of, my approach is, what's the data? If I don't have it, I'm not going to promote it.
The one that I would say has been very effective for me is just having all my fillings removed and having them replaced. But I also was going to ask you if your lecture, which is lovely, is on YouTube.
If my what?
If your lecture is on YouTube.
Yes. There we go.
So we can hear this again.
I expect you to memorize it.
Well, I was taking notes.
Sir.
So what's involved in taking advantage of your center in scheduling and cost and so forth?
A lot of money and a lot of time. And we'll be happy to talk about that with you. In general, it depends what it is we're doing. The full boat, the full first assessment, it's somewhere in the little bit less than $2,000 for all the testing and a couple of hours together. So that's the cost. But you don't have to do that. For certain people, a small portion of the assessment is what they need. So it can be a lot less than that.
Is it covered by insurance?
No, ma'am. It is not. Yes, ma'am.
How many staff members do you have, and what do they do? What are their roles?
Yep. So Dr. Michael Beedix, who started the practice a long time ago, a physician, and I are the two physicians. We have a nurse practitioner who sees primarily women in midlife, but she also sees patients for longevity. I see men and women in midlife, and I see all the longevity patients. We have a PA who does specifically sees men for testosterone. We have my assistant in the longevity program is a personal trainer, medical assistant, and she runs the gas analysis lab as well as the DEXA scanner. So she's not exclusively doing that, but primarily doing that. And then we have several medical assistants who help us with the medical portion of rooming patients, getting vital signs, that kind of thing. Yes, go ahead.
Could you talk a little bit about fasting and why you fast?
Right. I put these on just to get people to ask questions. I think fasting is, I'm not talking about 3-day fast. I'm talking about not eating 3 meals. I'm talking about giving your liver a period of time when it is not being bombarded by calories and metabolic byproducts of bacteria digesting food. Giving your liver a break is highly beneficial for its function. Now, fasting, I eat 1 meal a day. I've been doing it so long, I don't even remember. It was 15-something years ago. I love to eat a big meal. And I knew I'll eat 3 big meals. That's just how I am. I knew I couldn't do that and keep my slender physique. So I decided I could be hungry, but then I don't want to eat something the size of my palm. I want to have a big meal, and I could do that with 1 meal. That's why I did it. It's not very sophisticated, but I started doing that. Well, now there's a whole fetish about fasting. OMAD, and what's your window? And I mean, it's become this kind of ridiculous notion. I think fasting is important for metabolic health. We were not meant to eat 3 meals a day. We weren't. We are meant to starve. I mean, that for most of human existence, we have been living on very few calories, and we can well survive days without caloric intake. The problem now is too much deliciousness, too close to our hands, and it's ubiquitous. It's everywhere. You're always within about 50 feet of something yummy, right? You go out these doors. I mean, isn't that true? So I think fasting is very beneficial. It's what we did naturally years and years ago. Yes, ma'am.
Can you tell me your thoughts on the new full-body MRIs that are being offered?
Right. Very expensive. Very expensive. It's a great question. The reason that you would get a full-body MRI, it's a fishing expedition. You are looking for that cancer when it is too small to be known otherwise, but large enough to see on an MRI so that you can grab it and save yourself from the cancer because you got it early. Other things too, but primarily cancer. Does that work? It's not as clear as you might think. If you do MRI, let's say we all had an MRI of our body, a lot of us would have things that are not normal. If you look under a rock, you're going to see stuff you don't expect. Similarly with MRI. Let's say you do an MRI on me and they find a spot in my liver. Oh no, a spot in my liver? What could it be? It could be a liver cancer. A small one. If you get it now, well, you're probably going to be saved. What do I have to do? Well, you have to have a biopsy, which they numb you up and then put a needle in your side, put a needle in your liver, take a chunk of your liver, pull it out. Well, that doesn't sound like fun. It isn't fun. I didn't think I'd bleed afterwards. I didn't think I'd need to go back to the hospital. I didn't think I'd need some blood. Does that make sense? Yes. So much of what you find you didn't need to find. And some of the finding is very dangerous. And so you've got to put all that into the stew and ask the question, did I really find enough small malignancies to make a survival difference? I think it's dubious to me. There is a neat test called the GRAIL test. Has anyone heard of it? We offer it, but you can get it in other places. It's called a liquid biopsy. And this company, Gallery GRAIL, have developed a technique whereby we get just a peripheral blood. We just get your blood. And they can pick up solid tumor mutations from fragments of DNA that spin off the tumors before you find them. And so they can say, you know, hey, in your blood there's a trace of pancreatic cancer in the blood test. Let's get that CAT scan. And it turns out they have a pretty good track record. So I think that is more beneficial than a whole body MRI, and it's a heck of a lot less expensive. But those are both techniques to look for the occult tumor. Sir?
I have one question. Why is duckweed on your list?
Just because I love the name. Wolfia globosa. Wolfia globosa. It's an algae from the Far East. If you have visceral fat, adding that and green tea to your Mediterranean diet, you can't do any better. It's got proteins and polyphenols that are very favorable for liver function.
Where's the office, please? Where's your office?
Right on Outer Congress Street, right across from the airport, in that pretty white building. Thank you all for your attention. I really appreciate it.